Hello, good evening, everyone. Can you all hear me? Good evening.
Good evening.
So thank you very much for answering. So good evening, everyone. I'm Dimiji Olawi, Headquarters Administrator of FAMSA, which is Federation of African Medical Students Associations. So and I welcome you all to today's webinar, which is a panel session. So the panel session was organized in collaboration with the World Federation of Public Health Associations, and we've invited very distinguished guest speakers all over Africa to come and educate us, to come and discuss important details about decolonizing medical education, shaping training and practice for African healthcare realities. When checking through the participants, I can see that most of our panelists and other speakers have joined. So just give me a minute to introduce them. And please let's just wait for a few more minutes for a few more people to join in before we officially start the panel session. So thank you very much for joining. All right, so good evening once again. So let's start today's webinar. So once again, I'm Dimiji Olawi, the FAMSA Headquarters Administrator. And also on this call, today we have members of the Executive Council of FAMSA. We have the Vice President. We also have the Study Committee Chairpersons and the General Coordinators of FAMSA. And also we have our speakers here, our panelists here on the call. We have Professor Emiola Olapade Olaopa. We also have Dr. Bettina Kaunya. We also have Dr. Lucho Ingebert Bain. So thank you very much for joining. So we will officially start the panel discussion right away. So like I've introduced before, we have invited guests on the call with us. And also these other events, you will start with opening remarks, then you proceed to discuss a little introduction about FAMSA, then you move on to the panel session and questions and answers will follow, and we'll give closing remarks. So the opening remarks. So on behalf of Dr. Luwandumaki, he was meant to join us this evening for this panel session, but unfortunately he couldn't make it. Said he is feeling a little bit indisposed, and he really sent his apology, and he extends his regards to both the panelists and the participants and the attendees of this webinar. So on behalf of him, the Vice President, Bonventure Machuka, will give the opening remarks. Bonventure.
Okay, good evening, everyone. Thank you so much for this opportunity. My name is Bonventure Machuka. I'm the Vice President for FAMSA, and I'm from Kenya. My university is Moi University in the North Rift region of Kenya, in East Africa. So I take this opportunity, of course, to and I'm quite excited to meet all of the esteemed panelists and fellow medical students and all the guests in this call. And of course, it's an honor and privilege to stand before, to present, to speak before you today. And as we gather to discuss this critical issue, as we know, decolonizing medical education in Africa is not just a topic, but it's something that we need to on ourselves to be able to reclaim the agency, because how we train our medical schools, we need to foster the realities that are happening in our continent. Of course, the social, economic, epidemiological realities from our communities, from our nations, and many of the curricula, of course, are adaptations from foreign frameworks. So sometimes they don't fully cover the burden of disease. So as a student, as a medical student today, I think I'm quite excited to learn from these distinguished guests today. I think maybe why I feel like we need to decolonize, I think for contextual relevance, of course, representation, we need to have our own unique identity of curricula, of course, and also it's part of healthcare strengthening. The other time we are having a discussion around building global health strategies for our continent, and who's going to take charge in building these global health strategies, of course, who's going to take charge. Of course, we have medical education, medical schools, academia, and research institutions. They need to take charge so that we can strengthen the way we respond to the pandemics, the way the challenges that face our continent, including even brain drain, where our trained professionals leave the country for opportunities abroad. So also as a medical student, I'm quite excited to be the advocate of curricular reforms, research, innovation, and any other interdisciplinary collaboration. And I want to thank the World Federations of Public Health Associations for partnering with us in this event. And this is not just a discussion. I think it's like a movement, and FAMSA, in collaboration with all these organizations across the continent and globally, we are committed to ensure that medical education in Africa is for Africa, of course, and by Africa. Thank you so much for the opportunity. I look forward to the discussions and the insights. Thank you.
All right, so thank you very much, Bonventure, for that being beautiful remarks. So thank you very much, and I'm sure everyone is pumped up to listen to the opinions of our very distinguished speakers and panelists today. So thank you very much, Bonventure. So we'll proceed to the next item on the agenda, which is about FAMSA. So I'll be giving us a brief introduction, a brief overview about FAMSA. So FAMSA stands for the Federation of African Medical Students Associations, and is an independent, non-political federation of medical students associations all across Africa. So FAMSA envisions to become a strong network of medical students who are aware of global health issues and are responsive to the current questions facing the medical profession and global health. So a brief history of FAMSA. FAMSA was founded in 1968 as a Nigerian, Ghanaian, and Uganda initiative to foster the spirit of friendship and cooperation among African medical students. And since then, we've organized several events, several capacity building sessions, several general assemblies, several conferences So the 36th FAMSA General Assembly, which held in November 2022, was held in University of Zambia in Lusaka. The 32nd General Assembly held in December 2023 in Gambia, and the 33rd General Assembly held in November 2024 at the Obafemi Awolowo University, Ile-Ife, here in Nigeria. So this is a milestone. So since 1960 to 2025, in 1968, FAMSA started as a 3-country initiative, but now we are over all the regions of Africa, the North, West, East, South, and Central Africa, with over 240 registered medical student associations who are actively participating in the FAMSA activities. So here is a brief structure of FAMSA. We have the Executive Council, we have the regional councils, we have study committees, we have the General Assembly, at FAMSA headquarters, which is located in Nigeria. We have the technical working groups and the Medical Students Association, which is the unit of FAMSA. So briefly, in conclusion, you can contact us, especially the FAMSA headquarters, which is located in Nigeria, through the Office of the Provost, College of Medicine, University College Hospital, Ibadan. And here is our official email address, famsaarchives@gmail.com. Our website is live, www.famsanet.org. And we also have Instagram, Twitter, LinkedIn, Facebook, and all social media pages. So thank you very much for that. So now, not to waste our time, we will proceed to the panel session. So before then, I would like to read the citation of our panelists. So with us here today, we also have one of our panelists, Professor Emiola Oluwabunmi Olapade-Olaopa, who is the president of the Association of Medical Schools in Africa, a registered trustee of the World Federation for Medical Education. Is an advisor on health professionals and health system development to several African countries, international scientific and professional organizations, World Health Organization, and the government of the United States and Finland. He is a former member of the Council of the National Open University of Nigeria and the West African College of Surgeons. Currently, he is a professor and head of the Department of Surgery, University of Ibadan, and an honorary consultant urologist to the University College Hospital, Ibadan. Mr. Olapade-Olaopa's academic and professional career spans surgery, urology, molecular biology, medical education, biomedical research, and health system development. He is the 11th provost of the College of Medicine, University of Ibadan, and during his tenure, the college was ranked the highest in sub-Saharan Africa at the Times Higher Education World University Rankings for Medical Schools 2020 and 2021. He is also the vice chairman of Thomas Barcel Biomedical Foundation in Nigeria. Professor Olapade-Olaopa has a patent on over 150 scientific publications and 200 national and international invited presentations and abstracts. He is a fellow of the Nigerian Academies of Science, Medicine, and Medicine Specialties. So kindly let's join us together to appreciate or welcome Professor Emiola Oluwabunmi Olapade-Olaopa by using our emojis in our chat and by welcoming him to our chat. So thank you very much. Thank you for honoring our invitation, sir. Hello, sir. All right, so I would like to introduce the other panelists we have with us. So in today's personal panel discussion, we also have a distinguished physician. You have Dr. Lucho Njebels-Bain, who is a global public health physician, implementation research scientist, and empirical bioethicist with over 15 years of experience in global health. He has a diverse background with experience in adolescent sexual and reproductive health and rights, research and funding, research and empirical bioethics, health system strengthening, and the impact of climate change on sexual and reproductive health research. More recently, he has focused on disruptive and proactive science communication. He currently serves as the head of international programs at the African Population and Health Research Center, APHRC, in Nairobi, Kenya. Dr. Lucho is a member of the World Health Organization, WHO, Sexual Health and Wellbeing Advisory Group, technical expert to the Africa CDC on maternal, child, and adolescent health, and a member of the International Medical Advisory Panel of the International Planned Parenthood Federation, IPPF. So kindly join us together to invite and to welcome Dr. Lucho Njebel-Osbin. So thank you very much, sir, for honoring our invitation. Thank you very much, sir.
Thanks so much, the FAMSA family. I don't know whether you can hear me.
Yes, sir, we can hear you, sir.
Okay, thank you so much. No, thanks so much for the very generous introduction and for your team for taking this initiative to engage into very complex but very important subjects like decolonization of global health education. So as you mentioned, I work for the African Population and Health Research Center, which is an evidence policy organization, African-based, African-led, here, based, headquartered here in Nairobi, and with a regional office in Dakar, Senegal. And we have a mission. We have a mission to transform lives in Africa through research and African-led thought leadership and transformation of these lives. We believe that Africa is going to be changed by Africans. And this really, I think it connects squarely with the subject of the day when it comes to decolonization of global health education. I know my esteemed panelists are going to delve more maybe on some concrete aspects in terms of experiences. But I think I will be interested, my remarks will be more of rethinking what we mean by education, rethinking knowledge systems, and actually rethinking in a more structured way why the word decolonization and why it's important to continue using the word decolonization, or if it's really important to continue using the word decolonization. If you look at the discussion in the international development space, if you move from health to international development, generally, you're going to see that most people are becoming more comfortable with the word localization rather than decolonization. The localization agenda is actually becoming a very important, or more critical, less criticized subject. Maybe let's get to the basis of the decolonization of global health movement. I think it's important if we are talking about the importance and thinking and speaking and taking quite some action that something should be decolonized, therefore that thing was colonized. And this is actually one of the, from where I sit, one of the failures when it comes to the decolonization of global health movement. There are authors, it is very clear that if you look at the global health literature, decolonization of global health literature, for instance, you are going to see the people that are very, very vocal are actually either based in the global north, or they could be from the global south, but still based in the global north. So you see that the literature is still very, very dominated, not only in terms of publications, but in terms of leadership when it comes to the decolonization discourse in the global north. To me, I see that that is a problem. And you have writers that have written quite a lot. I'm thinking of the research fellow at Brown University, Daniel Krugman, who has written a very important paper published in PLOS Global Health on the elite capture of the decolonization of global health movement. If we're talking about decolonization, and most of the scholars that are leading the movement are still based in the global north, then it's an issue. And what if there is an agenda at some point where we are going to be we're certainly not going to be talking about decolonization of global health, but if you think along the lines of this elite capture of the decolonization of global health, we might come back to recolonization of knowledge systems of global health. Let's come let's think a little about the education dimension. As I mentioned, I think my colleagues are certainly going to be saying a lot of very concrete stuff, but I think it's important for us to think a little deeply. If we are talking about decolonization, it means there is some history to what we are talking about. But if we look at the literature in the space, I don't know whether you can really cite a very implicated historian or historian of science that is leading the discussion when it comes to decolonization of medical education, for instance, or when it comes to decolonization of global health as a whole. It therefore means there is some level of isolation of core disciplines that are really important to frame theoretically and to make the scholarship or the decolonization scholarship robust. So I really think the fact that we don't have many historians of science or historians, and we don't have, because we are talking about power. And if you talk about power, you're talking about negotiation. And if you're talking about negotiation, you're talking about diplomacy. You see that we have sidelined, either intentionally or unintentionally, historians that should guide us with when it comes to the theory, or diplomats or political scientists that should tell us how we should negotiate when it comes to the diplomatic dimensions of thinking through power. And at some point, I find myself, I say at some point, it's in French, they say usurpation de titre, meaning it's true, we know the problem, but there are others that could really help us in thinking through and bringing in more concrete practical solutions in how to solve this problem. Maybe at this point, I'm going to stop, but I think the decolonization movement is really important, but it's really for us as educationists or people that are, when it comes to scholarship, to really think around, is the scholarship around decolonization really deep? In my opinion, I think the scholarship is very superficial. Is the scholarship really structured? I would think it is really not very structured, because core disciplines that are supposed to discuss decolonization, if it is a historical concept, and if we are talking about power and negotiation, and we don't have political sciences and diplomats as core within this particular discussion, to me, there is a problem. And I really think in terms of scholarship, we have a clear elite capture of the decolonization scholarship and discussion. And that's why I think we still have a lot of work to do. So I would actually stop here and look forward to hearing from the panelists and answering any questions as they might come. Thank you.
Right, so thank you very much, Dr. Lucho and Jabez. Thank you very much for that. I think you've probably given the keynotes in person or on behalf of Dr. Luando Maki, who is unavoidably absent today. So thank you very much for giving us a good opening to today's discussion. Thank you very much, sir. So we would like to invite our third panelist today, who is also with us on this call. So kindly let us join us to invite Dr. Udina Kanyawu. Dr. Udina Kanyawu is an assistant professor of family medicine and assistant program director of the Global Health Fellowship at the Brown Family Medicine Residency in Rhode Island, USA, a Nigerian American physician scientist in training. Our work centers on advancing health equity through community-based research, decolonizing global health education for trainees at AMPATH, Kenya, that's the academic model providing access to healthcare and improving obstetrical outcomes for women of color. She brings extensive experience working across diverse settings, Rhode Island, Kenya, and Ghana, and promotes ethical, sustainable, and reciprocal global health partnerships. Dr. Anyawu also serves as the Diversity, Equity, and Inclusion DAI lead within our department and chairs the Equity Subcommittee of the Global Advisory Committee for the Center for Global Health Equity. She is deeply committed to reimagining medical education through a decolonial lens. Dr. Anyawu is honored to contribute to this year's Global Public Health Week panel and looks forward to engaging in meaningful dialogue around transforming medical education to center lived experiences, local expertise, and leadership. So thank you very much for honoring our invitation, Dr. Anyawu. So kindly let us join us here to welcome her. Dr. Anyawu.
Hello, and thank you so much for the invitation again. I am Dr. Anyawu, and I'm just so honored to be here and speaking to you guys. And I'll just, before beginning, I know that we will hopefully get into some extensive and in-depth conversations and discussions about decolonizing and how it relates to global health and medical education. But I do think that it's important to acknowledge my positionality. So maybe I'll just take a moment to do so briefly. As shared in my introduction, I do bring a wealth of academic experience related to global health equity, and what it means to decolonize. As we know, it's a concept that's really vast to define, but we may try to scratch the surface, and has also been named in the literature to be problematic as well, which we might also get to. But still, despite that research experience, I understand that my personal experience might be different from a lot of you on the call. I am a first generation Nigerian, and I have not schooled or trained in Africa or the African medical school. And I do not claim to have expertise over that experience. And so I hope that through my academic and my research experiences, through my collaborations with Brown Family Medicine and AMPATH, as well as the work that we've been doing in Kenya and Ghana, these collaborations have shaped how I deeply think about training, relationships with positionality, power, and oppression within the medical education. And so I hope that my remarks later can still be of service to you guys. And so thank you again for the invitation.
Thank you very much for that, Matt. Thank you very much for honoring your invitation. Thank you very much for giving your position on the topic. So let's start the panel session fully. So thank you very much. So once again, Dimeji Olawi, the moderator for today's panel session. And our three panelists are fully on seat now, and we'll start the panel session as soon as possible. So I would like to start with Professor Emiodaluwabumi Olapade. So the first question goes to you, sir. Sir, are you on the call right now, sir? Can you let me know if you can hear me, sir?
Yes, I am on the call. I had a little bit of an internet glitch, so I changed my internet provider. Thank you very much for inviting me to join this eminent group. I have listened to the introduction and the presentation by our lead, and I'm very happy to contribute wherever I can. So, do you wish me to make a comment on the topic at this point?
Yes, sir. Can you comment? Yes, sir.
Yes. My CV has been read, so I won't repeat it, but it does indicate that I've had broad experience in terms of medical education in Africa. What is not in my CV is that I did train for 11 years in the UK and in America, so I did also experience training in that concept. And I think that what I can immediately state is, as was said earlier, that there is not enough effort from Africans to decolonize themselves. And decolonization is going to take quite an effort because colonization was not necessarily done just to enslave you. It was done to aid the development of another part of the world. And therefore, what they brought into Africa was just to serve their own purposes. I am not as vitriolic or as offended by that action because they were looking out for themselves. And I think that it is our responsibility, if not indeed our duty, to then unbundle ourselves from the shackles. And the first thing you need to do is to rely on your own development. In most African countries today, medical education and medical research is funded from the West. In some countries, as high as 95%. So how do you then intend to decolonize yourself? The first thing you have to do is to fund yourself. When we were going to do the now old 2010 curriculum revision of the University of Ibadan, which is homegrown, the first part of that project was funded by MacArthur. But the second part, which was the implementation part, or the template part was funded by MacArthur. But the actual development of the curriculum was funded wholly by the University of Ibadan. That is why we could claim ownership of it. That's why we owned it, because we paid for it. So we need to pay for the necessary research that is going to allow us to have the data that is necessary for us to have medical education that is of global standards, but that is locally relevant. You can't expect external countries or external funders or external partners to do that for you. And until we're prepared to do that, I suspect that we shall just be jaw-jawing for the next 50 years as we had done for the last 50 years. That is where to start. And indeed, right now, there's an explosion of medical schools in Africa. The current report suggests close to 500. The question we need to ask is that an organic growth of medical schools? Do we have homegrown teachers that can actually staff those medical schools? Are they well versed in what are the health needs of our environment for them to design the curricula that would indeed direct the graduates to be able to handle those diseases, both elective and emergencies, when they come out or when they graduate? So we really need to start from basics. Until we do that, I'm afraid you have no choice but to continue to borrow from those who have done it before, who of necessity is the West. And they would always design their curricula, their research plans, their research projects, their development for their own benefit. They will never do it for you. And it is somewhat unwise, if not unrealistic, to expect someone else to fund your own development. So that is where I would say my position is. And as a result, we have tried in my own little world in Ibadan to try as much as possible to fund our own reforms. That does not mean you don't partner with external collaborators. No. Nobody has a monopoly of wisdom. You must learn from the others, but you must pay the greater part of it, and you must own it. You must go and do the research yourself on which you are going to generate the data on which you are going to base the template of the curriculum that you wish to espouse to say you are decolonized. Until that happens, nothing is going to improve. And finally, let me state that the danger in continuing to depend on external funders, as willing as they may be, as benevolent as they may be, is typified by what is happening in the United States now, where 83% of external funding has suddenly been cut because it is in their interest to do so. It is not necessarily simply because they want to be very mean to the rest of the world. It is just that at this present time, those in charge of the United States feel that it is in the best interest of their country to cut off external funding. You can only complain when you don't have your own funding. Why are you struggling with them with their funding? Find your funding. And that is the first way in which, or first thing that needs to be done for us to say we are decolonizing. But for as long as you are being fed by somebody else, I'm sorry, you can call it in many ways you like, you are still colonized. Thank you.
Thank you very much, sir, for bringing or shedding more light to the topic and giving us a position on the topic. So thank you very much, sir, for that. So we will kickstart the panel session fully now. Those that already started since. So my first question goes to you, sir, Professor Emiola Olapadiola. So with over 250 medical schools, like you said, now you have about 500 medical schools across Africa. So you are currently in the modern era of medical education in Africa, where we are experiencing new curricular innovations, such as problem-based and community-engaged learning. So the growth of postgraduate medical education in medical schools, growing research experience and funding, and a robust set of international partnerships. So despite this, a significant percentage of African medical schools still run medical curricula that are mainly Eurocentric. So my question is, I noticed that you attended the 2025 Med Africa conference in Kigali. We also have members of FAMSA who also attended the conference. So the conference highlighted the persistence of colonial era pedagogical frameworks. How can African institutions systematically audit and replace outdated Eurocentric content while maintaining global accreditation standards?
Well, thanks. I go back to what I said before. You need to fund yourself, and you need to have what is organic growth. There are enough competency-based medical education curricula across Africa now for those who wish to look inwards. But the fact of the matter is that curricular reform is not easy. The one we did in Ibadan that has since become acclaimed both nationally and internationally took us 10 years, and that's a lot of money. And that's because we needed to dig the foundation deep and get the data that would make it sustainable. It's unwise to ask many new medical schools to do that. And so what they will do is to borrow, as even Nigeria has more or less borrowed the Ibadan curriculum, is to borrow existing curricula. And where those schools are being founded in partnership with the Global North, then it is almost inevitable that the Global North will give them their own curriculum and say you should go and adopt it. There's no way you can run away from that. And it also comes down to the issue of the explosion of medical schools. Is it an organic growth? Can we really sustain this number of medical schools with homegrown resources? In 1943, when they were going to establish the first medical school in West Africa, the British government, it was decided that they could not afford to have two medical schools, which was why Ibadan was the first to be established in Anglophone West Africa. But the Ghanaians, wanting their own medical school, quickly put in a lot of money and a lot of pressure. But at that time, there were not enough resources to fund two medical schools, both in terms of staff and finances. So you can imagine that with 480, nobody needs to tell me that those schools cannot but be poorly funded. And when you are poorly funded, you have no choice but to look for people who will assist you. That inevitably will come from the Global North. And part of what you are going to take from that will be their curricula. So it is not that there is a persistence of the colonial curricula. There are curricula that have been developed by several medical schools that African medical schools could borrow from. But do they have their own resources to do so? Or are they relying on partners? There's no way you can be relying on partners to fund your medical education, and then you want to go and take curricula from somewhere else. It doesn't really work that way. So that is where to start. We need to have organic growth. We need, like any organism, we need to time our growth with the resources that are locally available. Share resources, I agree, that is the essence of organizations like AMSA, like FAMSA, and like several other consortia that are being established or that have been established. But for as long as you are relying on external funding, then unfortunately you cannot but have the persistence of colonial curricula. Thank you.
Thank you very much, sir, for that. So that's really explore and really emphasize the importance of self-funding medical curriculums by African medical schools. So because that's very key to the management or the designs of their own medical curriculums, and for them to better position or better train their medical students and health professionals in the local context. So the next question will go to Dr. Lucho. So my question goes thus: so several African medical schools currently, if you look inwardly, especially as medical students, they are designed in a way that we students spend a significant small percentage of our training time in clinical settings compared to in classes. So whereas the clinics and rural community postings that we do attend, they offer more exposure to contextualized training. So we are going to be doing these clinics and community postings. We are more closer, or we are closer to the community. We experience the local context to a very great extent. So what structural reforms are needed to transition African nations from lecture-heavy models to competency-based clinical immersion?
No, thanks so much for this question. And I honestly think in my view, 80% of the answer actually lies in the funding or in the investment. Everybody, or in general, that's the reflex. You go for what is cheaper, right? To transition from a clinic-based model to move students to the communities, that's going to take it takes quite some resources. It takes quite some resources to do a diagnosis of these specific communities, to know exactly how many students should go to which communities within what particular time frame. The students are not going to walk to these communities. They're supposed to need the students are going to need some transportation. To go to these communities, the students are supposed to survive. They're supposed to be lodged, you know? So I think it's, in terms of resources still play a very, very critical role in the kind of model, the kind of optimal model that we actually need. Yes, it's recognized that we need a community-oriented primary healthcare system. We need students to be versed with what's happening in the communities, because the diseases, the conditions, everything starts from communities before coming to the healthcare facility. And it's really basic that prevention is cheaper than cure. Prevention is surer than cure. We all know this. So all of this should actually happen in the communities. But as you said, yes, it's important. We need our healthcare, the future workforce to be versed with the communities they are going to work with. But how do you immerse them into these communities? It takes quite some resources. It takes quite some money. That's one from the resources side of things. The second thing, I think it also takes some level of a change in mindset. If you look at, I think Kenya is a very good example when it comes to the recognition of the importance and the value of community health workers, not as people who should just do work ad hoc, like actually pay community health workers. I think that's the next step that most of our health systems in the continent, that's the direction that we're actually going to take. Because these community health workers are within the communities, are trusted by the communities. They know exactly the dynamics, what's happening in the communities, and they can actually help us in diagnosing the problems and prioritizing on what kind of solutions can be most appropriate to these communities. And the solutions are certainly going to be cheaper, acceptable, sustainable, and whatsoever. So it takes a change in mindset to recognize the importance of community health workers by the future health workforce, because the doctors that are being trained today are going to be the leaders of tomorrow. So it's important for them to integrate the importance of community health workers, community health volunteers as a critical and important backbone of a primary healthcare system, because all healthcare starts from the primary healthcare system. Maybe another thing which I find that is really very, very critical. Everybody talks now about person-centered care, right? Person-centered policy making and whatsoever, personalized care, personalized healthcare. How can you make that connect if you really don't know the dynamics of what's happening in the communities? That's something that can really never happen. I've recently been involved in a project on antimicrobial resistance, and you're going to see, if you look at the funding on AMR, we all know that the burden of AMR is mostly in Africa. We recorded over 1 million deaths with the report published 2019, but most of the interventions, most of the research that is actually being done completely, most of the time, actually sidelines what's happening in the communities. But AMR resistance, everything, self-medication, over-the-counter drug taking, and all those things happen in the community. So if you are doing something and completely excluding the community, therefore you are either just preparing to fail or to do it again. So I agree with you. Yes, it's important to have this community immersion during training, but we need to raise some level of awareness. We need to have some level of political will when it comes to leadership, but that takes money. Thank you.
All right, so thank you very much, sir, for that. So Dr. Anyao, my next question goes to you. So Several African medical schools remain unranked globally due to the metrics prioritizing research output over community impact. But however, medical education in Africa comprises a unique blend of cultural, community, and hands-on training. So in your experience in the global education field or global medical education field, so how can African policymakers and medical education bodies challenge ranking systems that undervalue this contextual training?
Yeah, great question. I hope everyone can hear me okay.
Yes, ma'am.
Perfect. So whenever I talk and reflect on global ranking systems, especially within the context of Africa, the question I often ask myself is, what is the value and the benefits and reasons why we are seeking some of that validation from systems that may not even recognize the value in the very things that make our training here in Africa so impactful. I think that some of the scoring metrics unfortunately do reflect the priorities of high-income countries. This is by emphasizing things like authorship, first authorship, last authorship, publication volume, international recognition, funding from various resources, often while overlooking a lot of the things that you've named that matter most in the African context, such as retention of clinicians, particularly in rural or underserved areas, curriculum and education that responds more so to the public health needs and the community. For example, training programs that equip graduates to be able to lead certain initiatives or remain in underserved regions, whether that's through training and incentivization, which we can get into when we maybe discuss some policy later. While some of these things might not traditionally earn global prestige, we can't deny that they are in fact saving lives within these roles. And I will say I recognize that, the system is not neutral. I understand that these rankings do come with real incentives, whether that's visibility, ability to receive funding, which is very important, and promotion criteria as well. I think that what we could even consider or reimagine is what would it look like to have an African-led framework that actually reflects our contextual excellence, frameworks that honor the innovation in our actual curriculum and those things that truly define a medical education here that's grounded and rooted in equity and contextual relevance. Because I think ultimately that is what decolonizing that's what decolonizing asks of us to take a step back, to stop measuring ourselves by standards that weren't necessarily built with us in mind or our realities in mind or our local context, and to begin to start defining value on our own terms. And again, I recognize it's easier said than done. But I think when we start to move in this framing, we start to think about how we can build it and lead from within as opposed to externally. And I think that's a shift that we have to make on our own. And it's not one that will be necessarily handed to us. Thank you.
Thank you very much, Dr. Anyao, for that. So it's very important that we ourselves develop our own metric ourselves, that we even measure our progress over time, the progress of the improvements in medical education across Africa. Because this, like mentioned, the existing metrics, that's the global ranking system, might not actually reflect or might not actually prioritize the important aspect of medical education in African context. So that's really emphasized the importance of we probably developing our own metric system that actually reflects or prioritize the important things we focus on here in Africa. So my next question is go back to Professor Olakpade. So sir, so African medical students themselves, because we are the receiving end of medical education, we are the ones that are actively learning. So a decade ago, there was a popular campaign in South Africa, that's by South African medical students and nursing students, where they raised the issue of the decolonization of the curriculum. So they challenged the academic committee then. This was based on the fact that they felt the existing curriculum has inadequate content on African traditional indigenous knowledge and continues to use the Western approach to address the needs of a multicultural and multiracial and multi-ethnic societies. My question is, so how can medical schools effectively integrate evidence-based indigenous knowledge and practices into their curricula in order to enrich their students' learning and improve culturally sensitive patient care?
Thank you for that question. I would borrow from Dr. Lucio two things he mentioned. The first is a change in mindset. If you don't have a change in mindset, that's impossible. For the longest of times, orthodox medical training was fairly dismissive of indigenous knowledge, if not really hostile. And the truth of the matter is a lot of our indigenous knowledge is actually scientific. It may not, as Dr. Anyanwu has said, be in the metrics of the global north, but indeed we have not spent the time to develop our indigenous knowledge. We have been too interested in taking what was given to us, like I said, because we don't want to pay for it. We pay a lot for the orthodox medicine that we are being trained in. We just don't recognize it. But we want the traditional medicine people to give us their secrets for free. You don't want to go and study under them. For you, in my country, in my culture, for you to be a proper babalawo who knows enough to go out there, you need to be in training for a minimum of 15 years. For you to be an agbawo, which is the equivalent of a consultant, you need to have been in training for 30 years. For you to know which leaf you are supposed to pick. There are some that if you pick them in the morning, they are poisonous, they are safe at night, and there is vice versa. And we have many proverbs that tell us that if you cannot recognize one leaf from the other, you will soon be eating poison. So we need to have a change in mindset, and then to recognize that these traditional methodologies and their practitioners are in themselves expert, sometimes equivalent. And I can tell you, with the problem in Nigeria now with the exchange rate, a lot of my patients have turned to herbal medicine. Indeed, I have a local brew from a plant in my house that I can tell you works. I have the scientific evidence to show it, to prove it, because it helps flow rate. I have a before and after flow rate of a patient who is a professor of mathematics who agreed to be the guinea pig, just to show these things work. But you need to study them. Again, we need to invest. Back to Dr. Lucio. We need to spend money. Don't ask pharma to give you money to investigate what is going to make their drugs irrelevant. That is foolish. If you want to develop your own traditional indigenous knowledge, pay for it. That is the way you can put it in. Then you can have the scientific evidence that would allow you to put it in the curriculum. Just as we have the scientific data that allows us to do the orthodox curriculum, it is often emphasized or is often de-emphasized that you must develop your curriculum from ground up. We tend to develop our curricula from top down, and that is why it doesn't work. And that is why our graduates are better suited to the high-income countries from where the curriculum came. They are more comfortable. So, and that is why I said we're paying for it. I think Nigeria just put out figures that it lost $387 million to doctors who left the country. Yet you think you collected the curricula free, you thought you collected the research funding free, and you collected the vaccines free. But guess what? You are losing in terms of your graduates and your research and the ownership of data, the commercialization of the findings that are occurring from expatriate doctors, otherwise known as diasporans in the United States. All their discoveries are making America rich. They're not making Nigeria rich. Nigeria is waiting for crumbs. So it goes back to it. As my people say, it is the person who has the load that carries it from the heavy side. Stop asking other people to carry your load for you. So when our governments and our high net worth individuals behave like those in high income countries, fund startup companies, fund, there is one fund that they just give to researchers who have an idea that they don't know whether it will work or not, and they say, okay, we'll give you 100,000 to go and find out. Until we start doing things like that, and until we start respecting our traditional and indigenous knowledge and their practitioners, nobody is going to give you any information that would allow you to then put it into the curricula. One of my greatest claim to fame is that we did produce an anatomy book for beginners in Yoruba language. And it was such a fantastic experience because, first of all, we found out that there were so many words that were already in our indigenous language in the Ifa corpus, with the butchers. But more importantly was we now had to create new words. Some we borrowed, some we created, some were descriptive. All that is what is called development. If you continue along that line, you won't have to worry about putting it in the curriculum because it belongs to you. The students would have used those books in secondary school, so they will be able to use it to discuss with patients in medical school. And that's why I say you don't go from top down, you go from bottom up. You've got to initiate that. How many of our medical students actually speak their indigenous language for them to be able to converse with their patients in the indigenous language to the level in which they can understand what the patient is saying? So it's a real interesting area that there is such potential for development, provided, again, as Dr. Lucio said, we are prepared to have a different mindset and we are prepared to put the resources towards it. Those are the two things that are key. Thank you very much.
Right, so thank you very much for that and for the emphasis on going to the bottom to top approach. And you should, like has been said multiple times since the beginning of this panel session, the importance of investing in our own indigenous knowledge, in our own indigenous system, and to improve our current medical education in Africa. So my next question goes to Dr. Lucho. So, sir, there are previous and currently and the ongoing efforts to decolonize medical education in Africa, but some or most are even challenged with obstacles such as policy rigidity, institutional resistance, and limited funding, like has been said since. So, what strategies can be employed to overcome these barriers and promote a more inclusive and representative medical education system in Africa?
No, thanks so much for this question. And I think Prof has already answered this question. The first thing is you cannot be improving something without investing in what you want to improve. You need money. You need to invest. That's the first thing. But I think maybe I'll just go back to a couple of things when it comes to, as Prof mentioned, when it comes to, I really call it the explosion of medical schools in Africa. I'll take, for instance, Cameroon. I was trained in Cameroon. And by the time I was finishing medical school, we had 1 or 2 medical schools. As we speak, we have over 25 medical schools. In training then with 2 medical schools, we had issues with having consultants to mentor students. With 2 medical schools, you had issues with, and they were taking, and you had an intake of about 75 to 80 students every year. You had issues with having consultants to mentor students. Now you have over 20-something medical schools with an intake of over 2,000, 3,000 a year. So automatically there is an issue, as this growth actually has to be organic. It's not because we feel that we need medical schools that we must create medical schools. It's better not to have a medical doctor than to have a bad doctor. And I'm sorry to say this, we have a lot of bad doctors. And at times, the bad doctors that we are having because of our systems are actually a threat to our health. That is really important. The second thing I think I discuss with colleagues. I also discuss with a few friends who lecture in medical schools. And I think it's a general thing. I at times I have the impression that we don't set out time to think. We are in a particular period where people are kind of just suspended in the air. We don't actually sit to think. Because if we sit to think, there are a couple of things that by default we are going to question. As Prof mentioned, when it comes to indigenous knowledge or indigenous wisdom, who actually coined that word indigenous wisdom? Why is it indigenous? So we need to question knowledge. What is knowledge? What should be recognized by knowledge as knowledge? Who set the standards for this recognition? That's an important question. I think when I used to play football, what I missed in my life was that I was so distracted, and my grandmother had a lot of herbal solutions to a lot of ailments, and I was so distracted, and I didn't learn. My grandmother was like the doctor of the village, and people were coming and getting solutions, and they were healed. And the next thing, which is just a follow-up to the question of knowledge, what is expertise? Who is an expert? Who is a health expert? Why is a qualified babalawo not an expert, not a health expert? Why should we question all the time when people go to him? That's something that we are supposed to question. And not in terms of the process of recognition of expertise, the process of recognition of knowledge. We need to question the method. What do we consider an optimal method, an optimal methodology to get to true knowledge, if at all there is true knowledge to be recognized? So we need to question method as well. Knowledge is not just subjective, or knowledge is not just objective or measurable. And I really think tacit knowledge is the most important form of knowledge. And that's where we are missing it as Africans. There is a lot of tacit knowledge. Somebody tells you, I got this and was healed. The person was healed. That's it, period. Why are you questioning that? He got it and he was healed. The person is healed. That's it. So why should we always prioritize other types of knowledge or method over certain types of knowledge or method? And that's where the notion, I think Pai has written on this when it comes to allyship, global south, global health, global south. We need to have allyship in knowledge, because if we're talking about partnerships, we have to have intellectual humility to know that knowledge, the learning process is both ways. And we have to have epistemic respect. We need to respect all knowledge systems that exist, and to be fair enough and humble enough to know that each knowledge system or whatever knowledge system has an opportunity to learn from the other to get better. And maybe just the last thing I have to mention, which actually falls in line with what Prof actually mentioned, with most of our doctors that are actually trained and are practicing it in the UK, in Canada, or whatsoever. We need to question the agenda. What if we question and we think through that this is actually an agenda? I don't know how much it costs to train a doctor in the UK, in the US, but it's a lot of money compared to training these doctors in Nigeria, in Cameroon, and getting them for nothing or for free. So we need to question the agenda. So to me, I think we have a couple of very critical questions that we need to ask ourselves. We need to have this change of mindset. We need to live from that suspension in the air to calm down on the ground, to set out time, to set out fora, to set out consortia that just think, to question what is knowledge, what is power, what is agenda, what is method, what is expertise, before we can think of a meaningful, if at all it exists, decolonization of global health agenda. Nobody is going to come to fight for your recognition for you. You need to stand up for that. Nobody is going to come and help you. Thank you.
Thank you very much, Sir Dr. Ducho. So thank you very much for stressing the need for we taking the initiative ourselves, for we questioning the existing systems, we question the existing structures, and for we ourselves even questioning what is considered indigenous knowledge or indigenous practices. Of course, even the Eurocentric knowledge themselves, they are indigenous to themselves. Knowledge from France is indigenous to France, knowledge from America is indigenous to America, knowledge from Africa is indigenous to Africa. So why is ours just termed indigenous? Why not? Why is theirs not termed indigenous? So thank you very much for that. So I would like to ask the next question to Dr. Anyanwu. So the importance of aligning medical education in African medical education systems. So sorry, the importance of aligning medical education with the specific health needs of population is well recognized. Like, so knowledge, practice and knowledge has to be context specific, like we've explained before. So what key components should be restructured in African medical education systems to better address prevalent health issues such as infectious disease and maternal health? So in recent years, we had COVID, we currently have mpox ravaging all throughout Africa. So what key component of our existing African medical education systems should be better addressed to ensure we prevent prevalent health issues such as infectious disease and maternal health?
Thank you for your question. I believe that my colleagues here on the panel have already made some great points in regards to how we can better restructure our medical education system so that it actually is in alignment to serve the African healthcare needs. One of those major components being making sure that we're prioritizing knowledge, prioritizing our expertise, just prioritizing production of knowledge, ownership of knowledge and information as well. It's important that we create structures that actually reflect our local truths, elevates our local leadership, and as well as just prioritize knowledge production as well. I think that's one of the things that we mentioned, but I really want to reemphasize is just the criticality of having community engaged teachings and curriculum. From my personal experiences, as well as working with AMPATH, as I mentioned, which is the academic model providing access for healthcare. This is a decade-long partnership between Brown University and Kenya, and I've been able to witness some of just the remarkable enhancements that they've actually made to their curriculum, from similar to what Dr. Lucho mentioned, just simply with the incorporation of community workers, community healthcare workers, in regards to education, and having their medical students and trainees also exist and learn in these spaces as well. When the trainees are being trained in these community-based settings, and not just in the large hospitals, but they're actually getting a complete picture of what health looks like in multiple contexts. And so while you're understanding the disease, you're not only just understanding the disease, but the systems around it, which is just as important to be able to manage some of those infections and concerns that you've mentioned, such as monkeypox, COVID, as well. And so being able to understand how we can show up, not just as clinicians, but as advocates, as listeners, as leaders within this space, is just going to help enhance and shape and provide language and tools to be able to engage in the system that can more efficiently and effectively shape outcomes for our community members and for our patients. And I don't want to, sometimes when we think about restructuring, it's assuming that something is broken. And so I think the goal is to strengthen what is already working, support those who are leading, support those systems who are currently leading engagement with various infectious diseases. I'm just taking a systemic approach so that we're creating spaces for students and educators to be able to help shape some of those movements and what is to come. Thank you.
Thank you very much, Dr. Anyanwu. So a key component of what you have explained is the importance of strengthening the existing things that are working, the existing system and structure that are working. So that's very important. And as we also avoid overhauling or structuring every time. So it's very important to strengthen the existing ones and probably do a system monitoring and evaluation to identify the ones that are not working well and find ways to better replace them. So thank you very much for that. So my next question will be going to Professor again. So we have countries in Africa that Ekos mentioned. You have Ibadan Medical School, that's called University of Ibadan, that have done curricular reform. So have schools in other countries like Egypt. So in Egypt in 2017, the whole country himself, that's Egypt, implemented a radical reform to its undergraduate medical education program with a transition to a competency-based curriculum with early clinical exposure. So, sir, in your years of experience, especially as the president of the Association of Medical Schools in Africa, so can you share insights from these or other successful examples where African institutions have decolonized their medical education or their medical curricula, and what lessons can be learned from these cases?
Well, thank you very much for that question. Immediately, Makerere comes to mind. They not only revised their curriculum to a competency-based one after Ibadan had done so, they actually had the Meshal program, which was a very innovative program where 5 or so medical schools came together Makerere was the first one, and then the other medical schools, to share resources and allow their students to have exposure at the various universities, various colleges of medicine, particularly in the community areas. And that was a very good program. Problem, of course, was it was largely externally funded as usual. But it's something that could have been expanded across Africa. You have the CONSAMs, which followed on the Medunam, which was done by Namibia, now Rwanda, and other Southern African countries, where the medical schools again collaborated to develop what was a curriculum that looked inwards, mostly competency-based. I was involved with that, and to some extent problem-based. People forget that problem-based learning is a hugely resource-dependent curriculum. It requires 3 times the resources as a traditional curriculum. And that is why it does not work in Africa. It can't. You don't have the resources. We need to learn to be resource efficient. And I think the best example is the Tata Walter Sisulu curriculum, which really embedded students from an early stage of their training within the community in which they were to learn, and they lived in the community. They didn't have, like most medical schools, including Ibadan, have a fancy hostel where they stayed and there was 24-hour generator and you were trying to recreate the Radisson Blue. They stayed with the villagers in the villagers' huts and whatever abode they had. That is community training. And so they understood what the problems were. And so Africa has a lot of innovative curricula in bits and bobs that we can learn from. We've just got to learn, as we wrote in a paper in 2014, talking about networks, that North-South networks are good, but South-South networks are even better. And we need to create communities of practice. There's such a lot to learn from ourselves because we share many commonalities. We should look beyond what was done in 1918, where borders, artificial or otherwise, were drawn. In my country, for example, with Dr. Lucho, it was only a hill that separates us, and now we're suddenly supposed to be different countries. Until we look beyond that. And I was involved with the University of Buea. I was actually with them from 2010 to 2016, developing their curriculum to a competency-based one and fashioning out their assessment methods. It was a fantastic school. But like he said, we were struggling to get Buea resourced. And then all of a sudden I heard they had 9 other medical schools, and now he tells me they have 25. That's just not possible to maintain and then say you're looking for indigenous introduction. You can't. You're stretched so thin, you can barely breathe. Medical education is highly capital intensive. and it's highly resource intensive. So we need to be resource efficient. We need to develop more South-South collaborations. We need to stop being suspicious of our native knowledge and native environment. We need to understand that there are reasons for what they did. Some may have been crude, some may have been bad. Well, for God's sake, improve it. Don't discard it. Particularly since we do not understand the beginnings of the medical education that we teach, hence the problem. Because it did start from somewhere too. They didn't suddenly, I mean, it wasn't as if they had a vision or some miracle just happened and nobody put a USB in their head. They had to develop it. We need to develop ours. It is in our intent to develop ours with that mindset that we would go to Cameroon to go and learn that, oh, this is what you are doing. Then we'll go to Makerere to go and learn. When we were doing the Ibadan curriculum, we learned from Makerere, we learned from Walter Sisulu, we learned from Buya. And I'll tell you how we learned from Buya. I was aghast that Buya's entire medical faculty was less than the faculty of clinical sciences where I was coming from. Yet they had good students. They had brilliant students. So we needed to find out how they were doing it. So we need to do that. But the problem is, if you want to do that, you have to invest in yourself. If we are going to move forward, you've got to do the investment. Otherwise, you would grow. 480 medical schools is growth, but you will not develop. So you'll be a 60-year-old man with a feeding bottle in his mouth. You have not changed your dentition. The development is what makes you an adult. You can have 480 medical schools provided it was an organic growth. One begat the other as resources allowed. Then we will be able to take advantage of the various bits of innovation that everybody has to go through and everybody has to develop for us to stay alive. People tell me that the diaspora, that the best brains have left. I say no, the best brains are left. If the best brains weren't left, the entire health system would have collapsed. So yes, there is a lot of good brains out in the United States, but those here too, they must be good. They must be doing something. Otherwise, we'll be dropping on the streets like flies. That's not happening. So let's make it a point, particularly at the government level. It's beyond here. The government must learn to collaborate. They must learn to look beyond procurement and understand that they've got to develop what is in-house. Then we'll develop the industry. Then we'll develop the resources. We'll develop the textbooks. We'll develop the teaching methods. We'll develop the assessment methods that are relevant to our environment. And we have the benefit of the Global North to ensure that we standardize them. That is what we're supposed to learn from the Global North. So it's a matter of adaptation and not adoption. Thank you.
Thank you very much, sir, for that several points you've made. I can really keep up with all of them. So thank you very much, sir, for that. So that's quite comprehensive. So my next question also goes to Dr. Duchos, sir. Like I mentioned the other time, there have been student-led movements over the past decades, so such as the Fees Must Fall campaign in South Africa. And these movements and several movements that are not even led by students, are led by lecturers themselves, consultants themselves. They've demonstrated the power of students' advocacy or power of advocacy in initiating educational reforms. So my question is, so what roles can African medical students themselves, as we the students, what roles can we play in advocating for the decolonization of our medical curricula, and what platforms or strategies can we have proven effective over time?
No, thanks for this question. I think a couple of the answers have already been given by Prof. And I think FAMSA is already playing a role. I think we are already taking quite some leadership, because the future is yours and you are supposed to shape the future. That's one, but I think more initiatives than FAMSA are actually needed. I know if you do an assessment of what you are doing and the the number of medical students that are actually not aware of the existence of FAMSA, you'll be astonished. So good, you have already started, but it's important for this work for you to have in your plan to actually expand this work. That's one. And it's not just about expansion, but it's actually about concrete engagement and buying into an agenda. So what is the agenda? I think that's actually the critical question. The challenges are enormous, yes, of course. If you leave it only to the politicians or to the elders, they might not bring the kind of change that you expect, not in bad faith. At times we always consider that we don't get the expected change, or things don't move in the direction we want because they, in quotes, they don't want to change things. At times there are really quite a lot on the agenda, and you need to be more proactive, more strategic, identifying within the system, or within, I can call the generations, the elderly generations and the younger generations, to find like kind of champions to channel what you want. I think those are things that are really very, very, very critical. Yes, student movements have always been important, are important, and will still continue to be important. But I think, as you mentioned, and that actually aligns with my thinking as well, we need to sit back and actually rethink and strategize to see how we can create more impact. Everything cannot be done at the same time. We need to ask the most critical questions. What are the one or two top questions that, if addressed, can really are actually going to bring lasting change? Because at times when you go in, you want to do everything. At some point, you might not come up with anything. So I would think around the critical mass of engaged students. That's really important. I insist on engaged. That's important. Coming up with an agenda. What do we really want? Prioritizing and selecting one or two critical issues that have to be addressed in a very realistic time fashion, and identifying champions within and out of the system to actually champion these specific initiatives. It's really important what you are doing. It's not every medical student will have, and I really appreciate you guys for all of this. It's not all medical students that will set out time aside to dedicate in organizing all of this, sending out emails, looking at the literature, knowing what is actually happening in the space. It actually shows already that that's a very huge sign of leadership, that you as an organization, you're actually exemplifying. So you need a critical mass of realistic, rational, selfless individuals that have a clear direction, that recognize resilience as a very key feature when it comes to success in the long term. So to me, I'll actually reflect along those lines. Thank you.
Thank you very much, sir, for that. I'm very certain that even the Vice President and other FAMSA executives have been noting your recommendations for ways African medical students and our associations can better improve or can better advocate for changes in our medical education. Yeah, so thank you very much, sir, for that contribution. So my last question goes to Dr. Anyanwu. So we have effective policy changes are important to like Professor Olokwadeola has mentioned the other time, you need to involve governments. And Dr. Olucho has also mentioned you also need to involve medical education bodies, political offices in this kind of discussion. So what effective policy changes are important to institutionalizing decolonized medical education systems? So we need to institutionalize a very context-specific medical education system. So what specific policy recommendations would you propose to national governments and educational bodies to support and sustain the decolonization of medical education in Africa?
Thank you for the question. As we're all naming, Policy is actually one of the most powerful tools that we have to move from reflection to actionable change. With effective policies, we can actually shift where decisions are made, who sets the agenda, and how we can define excellence. And as we know, the goal with these policy recommendations is to create conditions within our African institutions, as well as within our training systems, so that they're on our own terms and so that we are active participants as opposed to being participants in someone else's story or someone else's vision. And so from my perspective, a few areas that could be particularly relevant in regards to policy recommendations to support decolonizing within the medical education space is one that we've touched upon. We've talked about brain drain or JAPA syndrome that we're all witnessing. And so, this retention policies, retention it's not just about producing graduates, but it's important to invest in systems through policy that can support them to stay, grow, and also lead within communities that they serve as well. Policies related to faculty development and leadership. Educators should be committed to work that is context-specific training, and so providing support in a way that they can elevate their clinical expertise and then be able to guide and produce equity-focused education is important. Policies surrounding equity and leadership as well. Education is also shaped by those who provide that training or teaching. And so it's important to create real and sustained space for diversity and leadership, which can be gender equity, women as well, to lead, shape, and also provide mentorship to the next generation. Certainly promotion and recognition criteria. It's very important that we are expanding, whether that's through government or institutional policies. We need to expand what actually counts. We need to make room for our African scholarship, for our knowledge systems, as we've been discussing, for our local health priorities to be recognized and rewarded. And so this could even look like supporting those journals that already exist within the Global South, or even creating and developing a strong Global South journal. The point is just visibility and strengthening, not as alternatives, certainly, but as spaces of authority so that our scholarship is produced and also reflects our local priorities, produced by us, reflects our own needs, our own priorities, in very context-specific expertise. That's important, that our lived experience are reflected in these spaces as well. And then, of course, policies related to research. As we've mentioned, African-led research, African-based research should be resourced and it should be protected. And this is not only because it obviously produces locally relevant solutions, but it can also create opportunities for students to be mentored at every stage, from research design to implementation to publication, authorship, and leadership. But this does require institutional support, institutional policies that perhaps provide protected time for our faculty who want to engage in this area of work. That's important. Protected time and paid time as well. This also requires that we discourage others who come in and conduct what we call parachute research, where they come in maybe with just personal motives and leave, engaging in ways that might be improper without appropriately educating those who are involved, without appropriately involving local experts in the research as well. And then not only that, but not disseminating the results of their study. And we need to have policies that discourage this type of research, discourage partnerships that take, as opposed to partnerships that are bidirectional and are reciprocal, where we're both gaining and we're both learning from each other, where all collaborators will benefit in a way that is equitable, okay, without without doing harm. Okay, those are just some examples. There's a lot of scholarship that already exists. I know Dr. Lucho mentioned Dr. Pai, who is a global health scholar that I follow, and he recently published an article. I'll find the name for you guys, but essentially also naming, okay, shifting power in global health will require leadership by Global South and allyship by the Global North. And so some additional policies that we can consider is certainly, again, incentivizing faculty for the work they do related to global South knowledge systems as well. But most importantly is the funding. We want to make sure that we are ensuring reciprocity and that there's just a lot of transparency and funding allocation, and that's all of us who are collaborating from both the Global North in this work as well. And so I think these are some of the that I would recommend in terms of.
All right, so thank you very much for that extensive contribution. Like you mentioned, policies are one of the best tools of implementation that we have. So, and like you mentioned, in terms of research, in terms of publicity, then in terms of clinical practice, in terms of several other things in the medical education system, we need to ensure that our national governments, our educational institutions implement these policies, not to enforce, not to ensure that even our efforts to decolonize or to improve existing medical education systems are actually actualized. So in the best interest of time, so I'd like to go around again with our panelists, but I want to just briefly, probably under 1 minute, just answer this question. So where do we foresee, or where do we see African medical education system, the students and the institutions themselves, where do we see the systems in the next 10 years? So what changes do you think will have happened in the next 10 years? So I'd like to start with Professor Olapade.
Thank you for that question. I think the future of medical education in Africa is bright for as long as the students typified by yourself continue to follow through with webinars like this, where they want to ensure they learn from not the past, but what has already gone, and use that to explain the present and then to reshape their future. Without any doubt, it is what the students want that is going to happen. We know that in curricular circles as the hidden curriculum. What is the intent of the students? If the students wish to decolonize medical education, then medical education will be decolonized. You have demonstrated such organizational capacity that I have no doubt in my mind that if you were to bring such forth to your medical schools, they would listen. So I think the future is bright. For people like myself, we will continue to guide, but we have to agree that we're in the twilight of our careers, and we just hope we have done enough to put a lamp that will lighten the path of those who are coming behind. Thank you very much for inviting me, and I congratulate you on what has been a wonderful program.
Thank you very much, sir, for that. So thank you very much. We are really honored with that. So thank you very much, sir. So I'd like to go to Dr. Onyebel's Dr. Richo.
No, thank you. I would not like to undo what Prof has already planted. I completely agree with him. I think the future is bright if we have conscious students like yourself that have a vision and that are actually intentional to move this path. Although it's, as Prof mentioned, it's not easy. It's going to take a lot of dedication. It's going to take a lot of selflessness. It's going to take a lot of resilience, but with focus and having a clear direction, because you are working for something meaningful, not for yourself, but for your countries and for the continent. The future is bright. Thank you.
Thank you very much, sir, for that. So Dr. Anyao.
Yes, thank you. And so I will try not to parrot or re-emphasize what has already been said. But my hope is that in 10 years, we'll see the African medical education systems that, it will be a system that's not just thriving, but actually will be setting the pace globally, and where we are reflecting our lived realities, our lived experiences, and where you all will be implementing trainings and communities that you'll serve. And that leadership will be shaped by those who are actually closest to those communities and closest to the work. Of course, we cannot get there by first naming, as we have already defined, the legacy of colonialism, and without understanding how it continues to shape our institutions, our priorities, even how we've defined success, how we've defined knowledge. And so the future, of course, has to begin with that clarity. And so I hope that with this conversation, we've provided some of that clarity so that now we can begin to move forward to the future with some intention. Okay. And so I believe and hope that the systems we'll be seeing will be deeply rooted in our values, within our knowledge, and that we'll be recognizing and prioritizing excellence as defined by ourselves. Okay. I would like to see stronger South-South networks, as we alluded to, where African institutions are collaborating across various networks and just leading the global health spaces, global health academic spaces, global health conferences in that manner, which unfortunately we're not seeing just yet. And I hope that they're also leading the partnership space in a way that, similarly as discussed, moves from a bottom to top approach, and not from a top-down approach or a place where there's hierarchy and power asymmetry. And again, I recognize that it will not happen overnight, but I do believe just in us having these conversations today, that shift has already started and it's already in motion. And so you guys that are all here are a big part of that why and how. And so thank you again for the invitation and for your time today.
Thank you very much for that. So, and we medical students and the future of healthcare profession, so we ourselves will ensure that we keep the flag flying and we put in our efforts to ensure the medical education system in Africa improves and also in this decrease over time. So thank you very much. So let's move on to the next section, which is question and answers. So let's kindly ask our questions. We have questions for our panelists. They've done a wonderful job. So it's best we ask questions we've kept in our mind since. So the floor is open for questions and answers. So could you indicate by raise of hand? Or could you just type your questions in the chat box? Okay, Aisha Abubakar can proceed.
Okay, thank you very much, Timothy. Please, can you hear me? would
Yes,
like
I
to
can hear
know
you.
if you can. Okay, thank you very much for the opportunity, and thank you very much for the presenters and panelists for sharing such wonderful information. My question here is that, like the panelists have mentioned, rural medical students are the future of medical education and medical practice. So I would like to know how can medical students engage, learn, or maybe train in medical education related matters? As we know, being trained in Nigeria, it's not easy to get involved in matters related to decision making in your medical education, or being involved also. So I'd like to know what are the best ways you can face these challenges, and getting first-hand information. Also, trainers are also just different opportunities you can get that would keep you to be more learned when it comes to matters of medical education systems. Thank you.
Thank you for that, Aisha. So, Professor Olakwa, would you like to answer that question, sir?
Yes, sorry, I was unmuted. Well, thank you for that question. I think as the famous saying goes, the beginning is a very good place to start. And where we need to start is to realize that medical education starts on the wards, and starts on when you go on community posting with patient interaction, and as has now been recognizing the patient as a person. And once that is embedded in you, then it becomes very easy to realize why or how you need to adjust your learning processes to ensure you achieve that goal of offering each patient the sort of advice, medical advice that recognizes his peculiar circumstances, which makes him a person. That will guide your learning, it will guide your training, it will guide your desire to do research, not just for research purposes, and it would also enlighten you to such an extent that you'll be able to identify the gaps in the medical education system as it is. As is often said, the cracked but the cracked vase is the best. That's how the light comes in. So it's nice to look for the cracks, but you can't look for the cracks if you've not really applied yourself to what exists at the moment. I always try and encourage students to say, we say you should think out of the box. We didn't say you should throw away the box. So kindly learn what is in the box first before you want to think out of the box. So I think if you do follow that as a guide, I think you'll find out that the rest will come to you easy. Thanks.
Thank you very much for that, sir. So, Dennis, you can go ahead.
Thank you very much, Dimeji. Thank you to all of the professors for enlightening us African students today. I'm Dennis from Liberia, and I would like to first start by quoting from Professor Laupade Olaupa. I hope I'm pronouncing it correctly. I think it's my third time, listening to him and learning. First, it was in Nigeria, then Kigali, and now here. So he mentioned that the colonization of Africa, was not just at our detriment, but it was at the benefit of the Western countries because they used that to develop themselves. And what that has done, in my opinion, is that it has created this gap that they almost always have the advancements, and we're always seeking that. So yes, it's important for us to decolonize health care in Africa, but I was kind of drawn to the fact that in medicine you have to keep up with the advancement. Like at the conference in Kigali, we're discussing the advancement of medical education in Africa, where you're trying to integrate things like artificial intelligence, using simulators and all of those ones. So I was just concerned, if we're decolonizing, does that mean detaching and not, affiliating or assimilating those innovations, or there is still a place for collaboration while decolonizing? How do we, go about? How do you ensure that you are collaborating with them, but they're not otherwise controlling the things that we're doing? Because medicine, like Prof from Cameroon said, is about providing good doctors more than just providing doctors at all. So that was just my concern. How can we keep up with the advancements that are usually available from the Western side while trying to stay independent as Africans? Thank you.
Thank you very much for that, Dennis. I think answering his question, I think the question is directed to Prof once again. First of all, look at the law person.
I actually thought Dr. Ayan would have been the best person to answer that question.
Okay, sir. Dr. Anyawu.
Thank you. And I'm happy to. Dennis, thank you for your question. You actually raised a very important question, and I appreciate your honesty and how you framed it. Because yes, as we've stated, colonization benefited the West, and it was essentially exploitation, okay, at the benefit of other people. And so this is not just history. This is a legacy and a relationship of exploitation and paternalism and oppression that continues to seep and thread the way that our medical education system and global health continues to persists today. You even see that inequity in the way funding is dispersed, where people or institutions from higher income countries are predominant receivers of funding as compared to folks from the global South. You often see that in global partnerships, unfortunately, where folks come in and they engage in very unethical practices. For example, this might look like entering the OR and not having the training, but feeling bold enough to do things within another setting or context that you otherwise do not have the training or capacity to do. Or another example of how we can, in these relationships, take advantage and exploit other people. And so when we say decolonization, we're not saying that we want to detach. What we are simply asking for is a place for equitable and bidirectional collaboration, where you learn and I both learn. We're exchanging knowledge, we're exchanging experiences, we are partnering, we're looking at each other as equals, not that I have a deficit and you're coming to fix me. We are both equals. I have my own background. I have my own level of expertise. You have your own level of expertise. How can we see each other as equals and from there build something great? Yes, there might be something that you have to teach me, but I also have something that I can equally teach you. And so there's that bidirectionality. There's even something within this space called reciprocal innovation, where now folks from the US, other high-income countries, they're actually taking programs that have been done very well in Africa. They're now seeing, for example, the community health workers is a great initiative. You know, in the US, community health workers is not something that we commonly use. But the literature is showing that community health workers are significantly improving health outcomes in Kenya, so much so that an institution in Indiana, they've actually now started adopting the same practices that they're doing in Kenya. And so that's something that we call reciprocal innovation, where you're also learning from your partnership. And so I hope to answer your question that we're trying to move away from extracting, from taking, from ravishing, which is what colonialism does, and what some parts of the global health relationship and partnership continues to do. We want to move towards a more collaborative approach, one that's respectable, is equitable, and also not one that just we come in and then we leave. The purpose is relationship building over time, sustainability, and longevity of whatever it is that you're doing, whether that's through institutions from the global South, so partnering within country as well, within whether you're in Nigeria or Liberia, and also between countries and even between continents. I hope that's answered your question.
Very much so. Dennis, so I'm certain that surely answers your question. So thank you very much for that, man. So we have a question in the chat box from Parrot. So she asked 2 questions. I think they are best answered by Dr. Lucho. So the first question goes also, what practical steps can medical students, educators, or even civil society take to demand budget allocation for transforming medical education systems in the continent? And also, how can we make medical education decolonization a political priority, not just an academic discussion? Sir?
Well, thanks so much for this very difficult questions. Yeah, as I mentioned, it's you should see change as a process. You don't expect things to just change overnight. And I really like the what Prof said. Now in economics and what's biz marketing, there is this red ocean thinking and blue ocean thinking. Like people just want to transition from the red ocean to the blue ocean. Things don't work that way. It's a continuum. It's a process. You cannot just want something exceptionally new without even mastering the foundations of the art. So I think integrating that dimension, that change is a process, is very critical. And I will still go back to what I mentioned. You need to be very strategic. You need to identify people that buy into your logic. You need to identify champions at the different strata of the society. You have students, you have lecturers, you have people that are within the administration of the universities. you have people within the political. So you need to identify champions that buy into your agenda, that would, because you are not going to be them all of the time when they sit to discuss those priorities. But if you have champions that already buy into your agenda, they are going to be presenting these important subjects when they actually sit on the table. And you need to make noise about it. Making noise without an agenda, without structure, without clear objectives, without an understanding of the process is not going to change anything. But having a very good agenda, very clear ambitions that are very, very good, and not making noise about it is just, you are simply just going to fail. I'm not saying that social media is everything, but I really have to recognize what you're already doing. Already, this webinar is a very, very huge tool. As already, it doesn't take 1 million people. It takes just a couple of very committed people who understand and buy into the agenda, and you are going to be amazed at the ripple effect based on learnings, these small learnings, as you might call small learnings, where you are exposed to these types of these kinds of opportunities. So to me, that's the way I'm going to see it, that don't underestimate the power of what you are doing. Continue pushing to identify champions that are going to buy into your agenda at various strata, at various levels, in different circles, and are going to be your voice when they sit on the tables that have to make those decisions. Thank you.
Thank you very much for that. So I believe so. It seems morning, like you could say, you've discussed a lot of things today, and I believe we've all learned and relearned a lot from our panelists. So one of the major things I have taken away from our discussions today is our panelists have mentioned we need to have a change in mindset at first, and we also need to increase our funding, and also we need to pull resources together to improve our existing medical education systems. And also we need to embrace rethinking in local context, like like Dr. Lucho mentioned. You need to set out time to think properly. Also, we also need to strengthen existing component of medical education systems that work, like that was suggested by Dr. Anyawu. And also, you need to embrace evidence-based indigenous practices and research, like Professor Olawale mentioned. So, and several other things that have been discussed during today's panel session. And also, we've also taken advices from our panelists on ways FAMSA and African medical institutions can further improve the existing medical education systems in Africa. So, thank you very much for that, for this discussion so far. So, let's just move to the last item on the agenda, which is the closing remarks by the Vice President, Bonmecho Machuka. Bon.
All right. Thank you so much. This has been quite a session that I normally enjoy. I normally enjoy watching Pan-African podcasts and things that are talking about Africa, what really Africa is. And today, really, we've had very insightful talks and great contribution and experiences. And of course, this shows the commitment that even our seniors have towards like the vision of our continent and what our future should look like. And of course, even the conversation has highlighted, of course, not only the challenges, but also incredible opportunities, because I also believe like in every challenge, every obstacle you face, it presents an opportunity, of course, to do things better. And I'm sure over time, things have been evolving. And I really take this opportunity to send my sincere gratefulness to our panelists. Of course, like the senior panelists, I think people are even eager for this panel. I've seen even people from YouTube. We have students from across the continent who have been able to access at least, and we understand maybe like, for example, Angry Birds, I think, is one of the difficult guys to find. But today we are very honored to have you and all the professors. Thank you, Dr. Odi. I think, Dr. Odi, we've interacted before on a fireside chat in the Global Health at our university. And I'm looking forward to such conversations. And I'm grateful that we had an honest conversation, especially with your experience in the Global North and your research works in the context of the the African countries. Thank you so much. It's my deepest gratitude also to the colleague medical students who were able to join, and all the contributions and the insights. And I think one thing that is clear here, like of course, the future of healthcare in our continent is just in our hands. Yeah, and yeah, instead of inheriting, we need to shape things that are happening. Yeah, so I'm a believer of communities, and just like when communities lead initiatives, because I think our problems normally start in the communities, and that's where they end. So if we invest in curricula that try to address things the way we do in Africa, like the holistic approach to healthcare, I feel like we can achieve more, and I think we'll have a better continent in terms of healthcare and the healthcare system. And we have other systemic issues that are facing our medical education. Of course, we have like the strikes that are happening in our universities, but some things that we can't control, some we can control. So I think it's also upon us to do what we can control at the moment. And I like what sorry about that. I like what Prof said. Like change, of course, it's a process. It's a process. It doesn't take one day before you can switch in. So thank you all. I wouldn't add anything. I wouldn't subtract anything. I'm just looking forward to such sessions. Thank you all for the time, your contributions, and of course, unwavering dedication to health in this continent. And of course, together we'll transform. Asante sana, that's what we say in Swahili. Merci beaucoup, I think in French, and thank you so much. Thank you.
Right, so thank you very much, Roberto, for that wonderful closing remarks. Thank you very much. Very big thank you to our panelists and so medical students who joined all across Africa. So thank you very much. And also our President Mohamed Sajjad says a big thank you, and he sends his regards to our panelists for joining today's session, though he's currently writing exams. That's why he couldn't join. So a big thank you to our panelists once again, and to all African medical students who made this webinar or this panel session a big success. So thank you very much, sir. And so good night, everyone. It's already late in the evening here in Nigeria. I'm sure it's the same weather is the same all across Africa. So thank you very much, everyone, and thank you for joining. And I wish us a great evening.
Bye-bye.
Bye, sir. Thank you.